chemicals already today in this talk, but also in everybody else's talk throughout the weekend. Nitric oxide has a lot of roles, but particularly, as we increase oxidative phosphorylation, sometimes nitric oxide builds up inside the mitochondria and actually clogs the mitochondria and decreases its efficiency. And so, as it turns out, red light helps to push that nitric oxide outside of the mitochondria, allowing it to do what it needs to do. It also increases nitric oxide release globally, so we get that endothelial response that we were talking about earlier, which is basically vasodilation, so increasing blood flow, thereby increasing oxygen. Reactive oxygen species, same thing as I said with hyperbaric. You're basically creating balance. So yes, some of the benefits of hyperbaric is absolutely the oxidative process. We have to irritate things a little bit to kind of get the response that we want. At the same time, we don't want the oxidative process to get out of hand. And so we want to have modalities that help balance the inflammation while we're creating the inflammation. So we don't go too far either which way. But the most important is the cytochrome C. Who here uses CoQ10? Right? Do you know why I use CoQ10? Do you know where it fits in the mitochondrial model? So, you guys see anything here? Oh, there we go. Right, so here's complex 1 and complex 2 on the electron transport system. So they're accepting the electrons from NAD8 and FADH2. You need to get from complex 1 to complex 2. So complex 1 and 2 to complex 3. And so there's a mobile carrier. You have to get from 1 and 2 over to complex 3. CoQ10 is that mobile carrier. And so in many cases, if you're deficient in CoQ10, you have a hard time continuing the process of getting those electrons down the road they need to get to in order to get to oxygen. Well, just like you would want to use CoQ10 because it's the mobile carrier to get from complex 1 and 2 to complex 3, cytochrome C is the mobile carrier that gets it from complex 3 to complex 4. Complex 4 is ultimately where it meets oxygen and it's the last electron acceptor. And so if we could stimulate cytochrome C the same way we stimulate CoQ10, we can move those electrons down the chain more efficiently. And so as it turns out, cytochrome C is a chromophore. It's very sensitive to certain frequencies of red light. And so if we give the body, especially a whole body treatment, have you guys seen whole body infrared stuff? So if you start giving the whole body decent doses of certain frequencies of red light, you could start to actually stimulate cytochrome C the same way you would using ubiquinol to change the mitochondrial function. So it's a pretty amazing tool, mitochondrial function-wise. So, mitochondria, ketones, and fasting. Who here uses ketosis, fasting? Fasting? Good. All right, cool. So, what does that have to do with the mitochondria? So much. Nutrition is a huge part, I think, of probably most people's practice. And I think all of these diets are great. Gluten-free, dairy-free, FODMAP, specific carbohydrate. They all have their place. They all have their purpose. All of them are basically trying to remove, again, toxicity and deficiency, right? So if we can remove certain foods that we know are pretty inflammatory or toxic for whatever reason they are, or if we could start to nourish the body so we're avoiding certain foods because we know that they're just basically empty calories. A lot of these diets are much better than the SAD diet. You guys know the SAD diet? Standard American diet? That's right, yeah, exactly. So any of these are better than that, but there's a reason to use ketosis and fasting. Because it's different. Why? It's different because, one, all those other diets, you're basically changing the macronutrient profile. You're removing gluten, let's say, you're removing dairy, or you're eating specific complex carbohydrates, trying to avoid some of the simple carbohydrates. But in all of them, you're still getting a high enough glucose injection at every meal to really never burn fat efficiently. And so that's one of the biggest differences with ketosis, is you're changing the body primarily from burning glucose to primarily burning fat. The other really important thing about ketosis is it's measurable. It's like, well, how paleo are you? Are you 100% paleo? Are you 80% paleo? Are you 100%? And who knows, right? Our patients could try to be doing a good job. They're telling the truth, but maybe this thing snuck in or that thing snuck in. We can't measure that really. Ketosis we can measure. We can measure your urine. We can know how many you're wasting. We can measure your blood, so we know how many you're building. We can measure your breath, so we know how many you're using. And so it's super objective to understand and just educate patients to say, look, here's how your body's changing as a result of this diet that you're doing. And so we use ketosis and fasting both sometimes together, sometimes separately. Sometimes we do one or the other depending on the patient, the case, and their issues. but it's a pretty special process. And so ultimately, what is it doing that's so different physiologically than pretty much every other diet out there? This simple term. So unlike Dr. Rosignol, whose first talk he said there won't be a quiz, there will be a quiz after this, so you better memorize this. Sorry. So primarily, we learn a lot of glycolysis, Krebs, and electron transport based on glucose metabolism. And so in that scenario, you're bringing glucose into the cell, you're breaking it down, you're making a couple ATP, you throw it into the mitochondria, you mix it with oxygen, and you're making 32, 36, depending on which book you want to read, I guess. So what this is saying that you need to not eat carbohydrate for periods of time. By the way, you're designed to not eat carbohydrates for certain periods of time. And we adapt really, really well to that. In fact, our ability to adapt in general is synonymous with our level of health, I would argue. So this is just creating dietary adaptation. And what we're going to do is we're going to not feed the system carbohydrate for some period of time. Some people go to a high protein diet. I would still say, basically high fat, moderate to low protein, but very low carbohydrate is the proper way for a few different reasons. But what we're going to do here is we're going to basically stop feeding the system glucose. The body's going to release glucagon and epinephrine. As a result of the release of glucagon and epinephrine, we're going to start getting fatty acids mobilized from adipose tissue into our blood supply. Now, those fatty acids can't free float. They have to be bound to albumin. Why is that important? Well, until recently, we didn't think the brain was capable of running off of fat, because you can't get fatty acids bound to albumin past the blood-brain barrier. And so if you can't get fatty acids bound to albumin past the blood-brain barrier, you can't possibly run the brain on fat. And so we would have thought that the whole brain runs on glucose exclusively no matter what. But what happens is you get so much fatty acids, long-chain, medium-chain, short-chain fatty acids going into the liver, you have so much acetyl-CoA. It's the same substrates regardless of the process, glucose or fat. But you get so much acetyl-CoA building up inside the liver, mitochondria, that the Krebs cycle slows down, it becomes sluggish. And so it starts to realize it's not getting enough glucose, so it actually makes its own. So part of, the amazing thing about the liver is the only cell that, or the only tissue that actually cannot burn ketones for fuel. And so it actually goes through gluconeogenesis. It takes those fats that it was burning, or trying to burn, and it shunts it back up the pathway, back to pyruvate and up to glucose, because it needs to fuel itself for function. And so it does half of it, not even half, but a small percentage goes through gluconeogenesis to start feeding that system, and the other part goes to ketone synthesis. In ketone synthesis, you're basically just packing acetyl-CoA together. So you've already broken it down, right? You've already taken it from a long chain or a medium chain triglyceride, and you're already broken it down to acetyl-CoA, so it's already like an energy packet. It's like ready to go. But now you're going to fuse two acetyl-CoA together, and you're going to send them back into the bloodstream. Why is that important? Well, ketones are water soluble. And because they're water soluble, they don't require albumin to go to the brain, and so they free float to all tissue. So we can get ketones, kidney prefers ketones, muscle tissue prefers ketones, and as it turns out, if the brain had a choice, it preferentially binds ketones over glucose. It's just we have to give it a chance. So you have to keep the glucose levels low enough, long enough to actually get this response. We've taken a lot of patients through this process, and they might, be good for a few days, right? And they have like a cheat meal here or there. We call it fat adaptation, right? Fat adaptation means that you've done this long enough where you're legitimately, your body now knows how to make ketones pretty efficiently. If you don't get to that process, what happens is people go in and out of ketosis all the time. And what you'll get is you'll get patients who measure urine because it's cheap and it's easy and it doesn't scare them. And they say, oh, I'm in ketosis. And I have all, you guys look at the ketone strips, urine strips, and so, oh, it's really purple. It's the most purple it could be. But if we measured their blood, it's not necessarily building in their blood. And the reason for it is because the body's not ready to use it as a fuel source. So you're building ketones, but you're getting rid of them. Ketones in your urine are discarded ketones. They're not used ketones. They're perfectly good, but the body's getting rid of them because it doesn't know what to do with them. As you become more fat adapted, the urine ketones actually start to go down. And then people get frustrated. I used to be dark purple, now I'm just getting this light pink. It's because your body's actually starting to use them. And if you went and measured blood, which is what we recommend for most patients, if you measured blood ketones, you would start to see as the urine ketones are going down, blood ketones are going up. If you took it a step farther, you could actually measure your breath, the acetone in your breath. And as a result, you could say, well, how many ketones did I actually use? Because it would show you the metabolism of ketosis. That's the quiz right there. Let's memorize that. So, that's a summary. We did that, we did that, we did that. This is in your book. It should be pretty accurate. So, these are just good charts. I think they're useful for you to learn. But what it shows, you know, let's say what this one shows, which is really interesting, is that infant metabolism is a very high ketosis. It only takes about 3 or 4 hours of fasting for an infant to go into ketones. Actually, mother's milk is actually pretty high medium chain triglyceride. But what that shows is how many hours and how many days and age ranges for when ketones would actually kick in. The top one up there just shows you that basically you need to get glucose to come down. It takes about 4 hours to burn dietary glucose. But it takes like 12 hours to get rid of your glycogen. And your body will burn through all your dietary glucose and all of your glycogen before it ever even considers making a ketone. And so for a lot of times, you need to be in this process for a good chunk of time before your body's going to really adapt to that process. That's the most important part, I think, of ketosis. You can, Cahill study, which I don't have a ton of time for, because I don't have a ton of time for right now. Does anyone know what time?
You have 5 minutes.
Okay, that's not enough time. So Cahill study, they will never repeat this in humans probably, but they basically took, I think it was 10 healthy adults, they fasted them for 40 days, they measured their acetoacetone and their beta-hydroxybutyrate, which are the 2 main ketones that our body makes. So what they basically saw was that over time, through fasting, their ketones started to rise and eventually leveled off. Their glucose plummeted, but then also leveled off. And I think it was Dr. New who talked about in some animal studies that they're still continuing to do, they basically then injected them with 20 units of insulin. And so their glucose plummeted. I think the average was the upper 20s. And there was zero change in cognitive or physical abilities. I can tell you that I do measure ketones and I do measure glucose in myself. And I've had many times, short spits, but like usually my glucose is around 72 to 74 in a fasted state. But I've had mornings where I woke up and my glucose was 30, 28, 30, 39, 42. And those are some of the mornings I wake up, I feel the best. And I think, wow, why am I out of ketosis all of a sudden? Why am I? But it's not. My glucose is that low, but my ketones have skyrocketed. And so if you measure that, you start to understand the relationships between glucose and ketones. It's pretty amazing. What are some of the general benefits of being in ketosis? Well, so obviously some fat loss because you're burning your own body fat as your main source of fuel. You'll start to see some hormone balance for sure as a result of that. You get reduction in inflammation. For the folks who deal with a lot of neurologic issues, you see amazing balance between the GABA and glutamate. And so if you're looking to reduce glutamate and improve GABA and improve that relationship between the two, ketosis is amazing for that process. And then also improved central nervous system metabolism. Specifically on the mitochondria, again, it's very normal for infants. It would be normal for us, except we went through a life of never going through that process, right? In fact, we were told to eat every 3 to 4 hours, eat 6 meals a day. For how long have we been saying that? And so what's interesting is if you measure glucose and hemoglobin A1C only, you would see that as a result, if you're not crazy eating donuts and everything every day, you would see that your blood sugar curve would be more normalized eating every 6 hours. Or, sorry, 6 times a day, every 3 or 4 hours. But if you measured insulin in that same period of time, what you would see is while your glucose looks much more normal and a healthier curve, and maybe it helps keep A1C from going out of control, your insulin is all over the map. And so what we're trying to do is we're trying to say, listen, we need both, right? For these people, especially diabetics, we need both of these systems to be balanced and healthy. We need the sugar system to be down, and we need the insulin system to also be down. So you get a lot of that with being in ketosis. It reduces the oxygen requirement. So all of a sudden, you don't need as much oxygen to get the same work done in the mitochondria for ATP production, and you have less carbon dioxide as a waste product. So all of a sudden, just like in a car, we're cleaning up the fuel as a way to reduce emissions, right? That's basically what ketosis is doing. We're cleaning the fuel. Fat burns much cleaner than glucose ever could. There's much less waste, and as a result, the mitochondria could become much more efficient at ATP production. And again, we get increased mitochondrial density. The body says, oh, look at all this extra energy I'm making. All these ketones are just floating. Right? Your body doesn't know how many to make. It just starts making ketones when it's appropriate to make ketones. And all of a sudden, most people in ketosis have enormous amounts of energy. I haven't eaten all day, can't you tell? But because of that, you're basically throwing so much excess energy into the system. The body wants to use it. And so it makes more mitochondria as a way to use that up. We basically talked about that. It's in your notes. Is it forever? I mean, just a summary. No. It could be. That's probably not ideal for most people. It's not necessarily the easiest lifestyle. But what I would say is while you're doing other dietary treatments, you are using paleo, you're using FODMAP, you're using specific carbohydrate, all of which are important, you still, if you actually got a patient to go through this process, you'll keep it. And so maybe you don't have to do it forever, but after you do it for a good chunk of time, you can go back to whatever other diet worked really well for that patient. And then maybe once a month you do a little bit of a fast, or maybe quarterly you do a month of ketosis, or one of these kinds of things, but you keep your toe in it so that you keep the benefits of having gone through that process in the first place. And what that does is it increases your capacity for carbohydrate. So I can tell you, most of my patients, myself included, my carbohydrate tolerance, I can eat many more carbs today than I could 3 or 4 years ago and still remain in ketosis because my body prefers it. So the glucose that I end up eating in whatever form it is, it's like jet fuel that burns right up real quick, but at the same time I'm able to maintain the level of ketosis because the body is used to it and it actually does prefer it. Summary. Okay, restoring function versus treating illness. We talked about that, right? We're not treating these issues. We're just trying to give the body the things that they need to heal. And I would argue that these are 3 really important ones. We need to do really good detective work. If we can go through a patient's life and history, figure out where their toxicities are, where their deficiencies are, and start getting rid of the things that they need to get rid of and helping get them the things that they need, we can start changing health. Plan nutritionally for restoring that. Ketosis, red light, hyperbaric, fabulous, all good. Synergy. So I'll basically just end with this. What I said before is I said, they're synergistic, right? They're not redundant. Think of the mitochondria as, it is basically a bacteria, right? So just think of it as a living organism. And just think that we could have mitochondrial dysfunction. Let's just say a mitochondria is working at 70%. But if we had twice as many, wouldn't that be good? Or let's say it's working at 70%, but if we could make them more efficient and get them to 80%, wouldn't that be better? And so here are 3 different modalities, and there are others. We'll use CoQ10 as one. So there's 4 different modalities that all work together just to say, here's some sort of mitochondrial dysfunction. How many ways can we improve it? How much more efficient can we make them? And can we make them have more so that even though they're not super efficient, when I double the amount, I increase the amount of energy that I was making. And so what I'm saying here is basically, you could read them, but we're adding certain nutrients basically to affect the mitochondria. We're changing the fuel source to make the mitochondria more dense. We're changing the fuel source to make it more efficient. We're stimulating the mobile carriers, CoQ10 and cytochrome C, to make sure that we're getting continuation of the electrons through the electron transport system. We're stimulating nitric oxide to get it out of the mitochondria because it clogs it up, but expose the tissue to more of it so we get better blood flow and oxygenation. We're balancing the reactive oxidant species. Basically, we're balancing the oxidative process within our body, so we're helping to deal with the oxidative stress of other therapies that we may be doing. And at the same time, we're then providing an increase in oxygen as that last electron acceptor so that we could basically make as much ATP as possible. That's the plant analogy, which is fabulous. We just don't have time to do it, so we'll do that next time. The end. Yes, thank you.
In how, if you're looking at sort of this 3-prong, using these different things and managing
Sure.
ketosis, do you change your therapy when you get kids or these people that are going into ketoacidosis because it's, they're not adapting well?
Sure. Are you having that experience? Are you measuring ketones in these kids? Okay. So absolutely. So the question is basically about ketoacidosis and using multiple. It's not like I don't have a protocol that says for this condition I do this much red light in these places, this much HBOT in these places, and this detox with this diet. We take each case as they come. We do as much work as we can to figure out their story. We monitor levels, things like that. I think typically, if they're getting into ketoacidosis, that's an issue. You could definitely dial that back. There are, I'm going to say, levels of ketosis. You can increase certain carbohydrate intake at certain intervals to try to get those levels down. The second that your body gets glucose, it converts back to glucose.
So you do primarily just dietary management then for ketoacidosis. You're not altering other therapies to try and bring that down.
Typically not. Yeah, typically we would manage that through the diet itself. Yes, sir.
Are you doing red light therapy as total body red light? Are you doing eyes, head? What are you doing?
So we do all the above. We have a couple smaller handheld lasers where we're targeting, let's say on the injury side, an elbow or a knee, on the brains, directly for brain stimulation or inflammatory issues like that. But then we're also doing full body, moderately high dose red light for purposes of things like that.
Are there any dangers of using the red light with cancer patients?
The studies are mixed on that. My take, it's not that new. I mean, there's probably more studies on red light than there are HBOT. But I think it's going to turn out to be kind of like, initially with HBOT, we talked about it about a couple hours ago. Initially with HBOT, everyone was like, no, you can't do that. Oxygen feeds cells. If we feed cells, we're going to feed cancer cells. And that turned out not to be the case. And so what I think is going to happen is, cancer cells don't utilize the electron transport system, right? They're basically fermenting lactate, right? We talked about that earlier. So, a lot of these cells are broken metabolically anyway. And so I don't think we're going to see that there's any negative effect on cancer. Depending on the distributor, or the company making them, there's a mixed stance on that currently. My own opinion is that I think we're going to find out that, the same way that hyperbaric feeds healthy cells what they need while killing cancer cells, I think we're going to find out that red light feeds healthy cells what they need, and at the same time makes it very uncomfortable for cancer cells. It's the same thing that ketosis basically kills cancer cells and feeds the healthy, so we're trying to, and even if you're using traditional therapies, let's say with cancer, you're using chemo and radiation, they're doing plenty of studies with ketosis and HBOT, right? They're mixing those. But what we're going to see is that we're saving, even if that means that we could tolerate, in some studies, they're increasing the radiation dose because patients are tolerating more radiation because they're getting healthier. And so if that targeted therapy is that important for that patient, then maybe that's great. So we're making them healthier, their healthy tissues healthy, they're going to survive the treatment. Now we can increase their dose. Or in other cases, maybe they don't need as much of that traditional treatment because the rest of their body's getting healthier and we're finding balance and regulation through just helping heal the tissue. Yes, sir.
Is there a particular blood level of CoQ10 you're shooting for?
I actually do not measure blood levels of CoQ10, so I don't have an answer for that, but I'm sure we have it in this room. Anything else? All right. I'll be here for the question and answer too. Thank you. Thank you.